thank the organizers, Dr. Samir and Dr. Viraj, for inviting me here today. So the topic has been chosen most probably by Dr. Viraj only. So very smart chap. He wanted to listen from me that there is no role of radiation in gastric cancer. So I'll try to give an unbiased opinion on this. And which one? Starting, I want to acknowledge Dr. Indranin Mollik because he has shared his slides and he has guided me for preparing this presentation. So let us see why we should consider radiation in stomach cancer. So with this traditional resection, that is either D0 or D1 resection, so there was a significant amount of failure in the surgical bed, around 40 to 65%. So we have adequate evidence that adding adjuvant radiotherapy improves loco-regional control and probably improves the survival as well. So we have preliminary evidence of radiotherapy. There are many trials, like as old as published in 1982. There is one journal which was a phase 3 trial of neoadjuvant radiotherapy for cancers in gastric cancer. It was a 370 patients data. We had few smaller phase 3 trials which showed survival benefit. And we had trials for unresectable gastric cancer. There are 10 to 20% long-term survivals with RT and 5FU. Then came this data we call McDonald's regimen or intergroup trial, where a resected gastric and gastroesophageal junction adenocarcinomas. So after a R0 resection, there are two arms. One is an observation arm, another is adjuvant chemoradiotherapy arm. And as we all know, it has been discussed in many forums and many times. I think in all stomach cancer discussion, this trial is discussed. And there was an overall survival benefit with adding adjuvant chemotherapy, 36 months versus 27 months. And grade 3 toxicities were around 41% and 1% mortality. The updated result of intergroup trial also shows that there is overall survival benefit, which is statistically significant, and also a benefit in relapse-free survival. But what about D2 gastrectomy? Because these data is for D0 or D1 gastrectomy. So Japanese Research Society for Study of Gastric Cancer has defined D2 is, it's actually N1 is the perigastric lymph node stations along lesser curvature and greater curvature, and N2 is nodes along the left gastric artery, common hepatic artery, celiac artery, and splenic artery. So D2 gastrectomy is considered the current standard of care, and at most of the centers now, they are practicing D2 gastrectomy. So D2 gastrectomy has definitely improved the survival, definitely improved the outcome. And in intergroup trial, as we can see, there are only 10% patients who had D2 gastrectomy, and most of the patients had D1 or less than D1 gastrectomy. So, what after after D2 gastrectomy, what is the protocol that we follow? So if there is an upfront D2 gastrectomy, we can use adjuvant chemo plus radiation, we can use adjuvant chemo, or we can use a perioperative chemotherapy regimen and do a D2 gastrectomy. So these are the options available. So what about the perioperative chemotherapy? This trial has been discussed in the morning, the MAGIC trial, perioperative 3-cycle ECF followed by surgery and then adjuvant chemotherapy, and it shows that there is overall survival benefit. That was 36 months versus 27 months. And the MAGIC trial, this is the number of D1 resection and D2 resections, and there also a number of patients had D1 resection, D1 or less than D1 resection, and there are few patients who had D2 resection as well. Then came this FLOT4 trial. FLOT4 trial is for perioperative chemotherapy with docetaxel, oxaliplatin, leucovorin, and 5FU. And FLOT trial has actually shown that we had a survival of around 35, 36 months, but with FLOT trial, the survival was 50 months. And it's a very good trial, and readily people have accepted that FLOT trial they have adopted in their practice, and there was no difference in side effect profile, death, or hospitalization. So, the adjuvant chemoradiotherapy, the chemotherapy post D2 resection, there is a Japanese trial. So they had a significant benefit with S1 because this is the popular drug they use in Japan. So from 5-year overall survival was 72% versus 61%. And there is a Korean trial called classic trial, post-D2 lymphadenectomy observation versus capecitabine plus oxaliplatin. There is a significant benefit if we use post-operative chemotherapy. So then came this post-op chemoradiation trial or the ARTIST trial. So they tried to see if you give only post-op chemotherapy versus post-op chemoradiotherapy. Chemotherapy was given 6-cycle capecitabine, BID with cisplatin, and radiotherapy was 45 gray in 25 fraction in 5 weeks time, concurrently with capecitabine after 2 cycles of XP. So there was a good number of patients, but unfortunately there was no significant difference in DFS or OS with the addition of radiotherapy. So at a post-hoc analysis, they tried to find out is there any subgroup which actually benefits from post-op radiation, chemoradiation. So they found that nodal metastasis and intestinal type of histology, they actually get a significant benefit with the addition of radiotherapy. So in a longer follow-up also, locoregional relapse was more frequent in that chemotherapy arm than chemoradiotherapy arm, and distant metastases were observed around 27% and 24% of patients in chemotherapy and chemoradiotherapy arm. So in nodes, they have seen that the nodes ratio, that is positive lymph node and divided by number of lymph node dissected categories. If it is 0%, 1 to 9%, 10 to 25%, and more than 25%, the hazard ratio was 1, 1.06, 1.2, and 3.57 respectively. In patient having a node ratio more than 25%, the 5-year DFS rate was 55% and 28% for radiotherapy and only chemotherapy arm respectively. So they have designed another trial called ARTIST-2 trial. This is only for the node-positive patients, the D2 resected stage 2 to stage 3 node-positive patient, 3-arm trial. One is only chemotherapy with S1, another is adding 2 chemotherapy regimens, and the third one is with radiotherapy. So we had an interim result of 3-year DFS. As we can see, compared to monotherapy result, the multiple agent chemotherapy result and chemoradiotherapy results are good, but there is a catch in this. This trial was not designed to compare chemotherapy versus chemoradiotherapy. And another drawback of this trial is that they had planned to recruit 900 patients, but they stopped it in between after 546 patients because there was a clear benefit of adding multiple agent chemotherapy and chemoradiotherapy. So the ARTIST-2 trial result has been published, and unfortunately there was no benefit of adding radiotherapy. So they have concluded that in patient with curative D2 resected stage 2-3 node-positive gastric cancer, adjuvant SOX or SOX-RT were effective in prolonging DFS when compared to S1 only monotherapy. So both were quite equivalent compared to S1 monotherapy. However, the addition of radiotherapy to SOX did not significantly reduce the rate of disease recurrence after D2 gastrectomy. Based on the result of ARTIST-2 trial, they said that we believe that adjuvant SOX should be the standard of care, and those are treated with D2 gastrectomy. So there was another trial with peri-op chemotherapy, that is the critic trial. So the one group of patients got only post-op chemotherapy, and one group of patients got post-op chemoradiotherapy after pre-op chemotherapy and D2 gastrectomy. So there was 788 patients data. 84% completed 3 cycles before surgery, and the radiotherapy regimen was similar. And at a median follow-up of 61.4 months, median overall survival was 43 months with chemo and 37 months with chemoradiotherapy. So there was no benefit found of adding radiotherapy in this scenario. So in subgroup analysis also, there was actually no benefit, and no information on benefit of radiotherapy in YP2 or N2 or N3 disease. So if we compare this, all the trials, so McDonald mostly D0 or D1 resection, there was a benefit. MAGIC trial, D1, D2 resection with a perioperative chemo, there was good benefit. With FLOT trial, there was benefit of adding perioperative chemo. ARTIST trial, actually there was no benefit of adding radiotherapy to chemotherapy, and CRITICS trial also says the same. So why do we stand with post-op radiotherapy? So it improves DFS and OS after D0, D1, and role is uncertain with D2 gastrectomy in the adjuvant or a perioperative setting. So if we get an operable gastric cancer and if we do an upfront gastrectomy, that is D0 or D1, we definitely will go for post-op chemoradiotherapy using the McDonald or the artist protocol. And if we are using a perioperative chemotherapy, MAGIC or FLOT with D2 gastrectomy, then we'll use only perioperative chemotherapy. And if we do a upfront D2 gastrectomy, then we can do two things. One is post-op chemo RT for node positive as per artist protocol, because both are same, and also we can use post-op chemotherapy alone as per the artist protocol, because both has shown similar benefits. So what about pre-operative chemoradiation? The advantage is the target delineation is quite easier with pre-operative chemoradiation, less normal tissue in the field, less toxicity, and the advantage proven in the esophagus with cross trial. So we have few evidences of pre-operative chemoradiation. So there was one study called the POET study where pre-operative chemo was used with cisplatin 5-FU, and then chemoradiation, and one group had no further chemo, and then a D2 gastrectomy was done. So it was found that there is a non-significant increase in 3-year OS from 27.7% to 47.4%, and post-op mortality was slightly higher in chemoradiotherapy, though it was not statistically significant, but it was actually closed early because of slow accrual. Another study called Top Gear trial with 752 patients. The primary endpoint was overall survival, and there was two groups, one control with ECF or ECX into 3, another is ECF into 2 plus preoperative radiotherapy, then surgery, followed by the rest of the chemotherapy circles. So the interim analysis says that there is no increased toxicity or surgical morbidity. So we are waiting for the results. And another study called NeoCrack study, which is quite similar with Xelox chemotherapy or Xelox chemotherapy into 3 plus RT, then D2, and then the rest of the chemotherapy. And it's a multi-center Chinese study with 620 patients, and primary endpoint is 3-year DFS, secondary is OS and pathological CR. The results are awaited. So where do we stand in 2022? So in the setting of D0, D1 upfront gastrectomy, yes, post-op chemo RT is still the standard of care. The role of post-op RT in the setting of D2 gastrectomy is under question. Recent randomized control trials do not show benefit of adding radiotherapy to multi-drug adjuvant perioperative chemotherapy. So subset of patients who may benefit will need to be identified, like histology, lymph node ratio, patients who don't benefit from the chemotherapy. So pre-op radiotherapy is under investigation, and I also strongly believe that pre-op chemotherapy may be a game changer here. And radiotherapy toxicity is much less a concern now with IMRT, because most of the older trials, they used a conventional technique with bigger fields like APPA fields, but now we use IMRT techniques, and toxicities are actually not much of concern. And after a perioperative chemotherapy, if there is a RPLAS resection, so we need to think whether do we add any local radiotherapy to that or not. So thank you all. I think I have cleared my points on this topic.